Today, the heart failure session is session 3, and I would like to welcome to the stage our 2 guest speakers and our panelists. Dr. Andrew Lenneman. Dr. Lenneman is an assistant professor of medicine at the University of Louisville and specializes in advanced heart failure and transplant cardiology. Dr. Lenneman has cared for over 200 patients who have left ventricular assist device and many more who have had cardiac transplantation. He will be presenting on identifying stage D patients with heart failure, when to refer for advanced therapies. Dr. Lenneman. Dr. Mark Slaughter is a professor and chair of the Department of Cardiovascular and Thoracic Surgery at the University of Louisville and the director of Heart Transplant and Mechanical Assist Device Program at Jewish Hospital in Louisville. He is an internationally acclaimed expert in heart transplant and ventricular assist devices. Dr. Slaughter has published over 170 articles, many of which are on LVAD. And just to tell you a personal story, Dr. Slaughter, when your article came out on LVAD in New England Journal of Medicine 2009, reading that as an internal medicine resident at the time, I was really piqued in going into cardiology and going into transplant cardiology and taking care of patients with really advanced heart failure as well. So thank you very much for publishing that well-renowned article. Today he'll be talking to us about left ventricular assist device, current outcomes, and future directions. I would also like to welcome to the stage Dr. Abdul Wahid. Dr. Wahid is trained in advanced heart failure and transplant cardiology, in addition to interventional cardiology. He has been board certified in advanced heart failure and transplant cardiology since 2012. Dr. Wahid also serves as our Associate Director of Heart Failure at WKHL. As a heart failure fellow at the University of Cincinnati, he investigated the prognostic value of the left atrial size in transplanted heart and assessed optimal surgical techniques for left atrial anastomosis during transplant. Dr. Wahid was also involved with conduction of various important heart failure trials there at University of Cincinnati, including HF Action and Ascend HF. Help me in welcoming these 3 very important physicians to the stage. Thank you, Dr. Lenneman.
All right, well, thank you all. I'm honored to be here. There's been some excellent presentations and some really excellent conversations and discussion as well, and I hope that continues here. I'm really excited to be talking to you today about identifying stage D heart failure, when to consider for advanced therapies. So some heart failure facts. Heart failure is a huge problem that's not going away. U.S. prevalence is around 6 million with almost 700,000 new cases per year. Very poor survival outlooks in many cases, less than 5 years. Heart failure is the only cardiovascular disease which is currently on the rise. As was touched on a bit earlier, heart failure hospitalizations are one of the biggest expenses for our healthcare system today, and one of our biggest areas for improvement, and also very important as we consider hospital reimbursement. So we have a huge opportunity here in Kentucky because we sit right here in the heart failure belt where all throughout the Southeast having the highest rates of death among heart failure patients through the United States. So we're going to talk a little bit about the progression of heart failure today, about the characteristics of advanced heart failure, and also review some of the current treatment options and outcomes with advanced heart failure therapies. So around 2001, our heart failure guidelines changed a little bit, and they changed so that we could identify patients here at stage A who are high risk of developing heart failure, but before they had symptoms. The idea was to treat risk factors and prevent the progression of heart failure. So these patients with stage A heart failure are high risk, but don't have symptoms yet. The next step is stage B with patients with structural heart disease, but who have not developed symptoms of heart failure. We can treat these stage B patients with ACE inhibitors, in most patients, and beta blockers also in many patients as well, and improve outcomes even before people have developed symptoms of heart failure. But once they do develop symptoms of heart failure, then they become stage C. They have structural heart disease, and this is a very important distinction, that they have previous or current symptoms of heart failure. So if you have a heart failure exacerbation, and you're treated, and you improve, your symptoms improve and resolve, you're still at stage C heart failure, excuse me. We have many treatments directed at patients with stage C heart failure, including ACE inhibitors and beta blockers in all patients. Dietary sodium restriction, it's not just all about medications in these folks. Diuretics, of course, can improve patient symptoms. Cardiac resynchronization therapy in many patients, revascularization and other valvular surgeries when applicable. At this point, we want to be considering a multidisciplinary team, which was also mentioned in some of the previous sessions. Also, aldosterone antagonists have come about as well and improved patient outcomes. But about 5 to 10% of these patients with symptomatic heart failure, despite good guidelines-based medical therapy, will go on to develop refractory symptoms requiring special interventions, and we're going to talk about some of these therapies here today. Heart failure therapies have really changed in the last 30 years. In the early 90s, the ACE inhibitor trials came along and improved our mortality a bit. A little bit later on in the 90s, late 90s and early 2000s, really some of the practice-changing beta blocker therapies came along, and we were continually able to improve our outcomes in patients with heart failure. Then SCUD-HEF came along in 2005, which showed us the importance of primary prevention defibrillators in patients with heart failure and reduced ejection fraction. So this is a really exciting time to be in heart failure. In fact, just last month, or actually in July of this year, we've had 2 new medications which are FDA approved for the treatment of heart failure. Valsartan and sacubitril, which was previously referred to as the catchy name of LCZ696, and then ivabradine. These are really exciting treatments, and I think they may even change the way that we practice heart failure again, which is one of the reasons that heart failure practitioners are so excited about the future of heart failure. The good news with advanced heart failure also is that we have treatment options even in the most advanced cases, and there's such rapidly changing and improving technology, and I think Dr. Slaughter is going to touch on some of this a little bit later. So we're going to talk right here about the progression of heart failure. So again, our stage A patients, they're patients with coronary artery disease or diabetes or hypertension, risk factors for developing heart failure. And this could potentially cause left ventricular injury, which leads to neurohormonal stimulation, endothelial dysfunction, and adverse ventricular remodeling, which brings us to our stage B patients. It's important to do screening tests for people with risk factors and identify those patients who've had ventricular remodeling and damage to their ventricle. Then along comes stage C patients. Again, neurohormonal stimulation, endothelial dysfunction, vasoconstriction, sodium retention all lead to the development of heart failure symptoms. And sometimes, even with excellent guidelines-based heart failure therapies, sometimes we develop end-stage heart failure, pump failure, arrhythmia, and people with heart failure die. So it's very important to you get to these patients early, identify patients, and get them on guidelines-based medical therapy. So stage D patients, what to do when all else fails. So these patients, stage D heart failure is highly lethal. Most patients die within a year, and we'll show you some of the data that brings us to that conclusion. It does not travel alone. So many of our patients have other comorbidities that further complicates their heart failure management. Lung disease, renal failure, complications of diabetes and liver disease. And also, it's important to note that these patients have a very poor quality of life. Depression, pain, and quality of life scores are oftentimes worse than those who have the most advanced types of cancer. So when comparing advanced heart failure patients to cancer patients, the quality of life is very poor. the prognosis with end-stage heart failure on optimal medical management, once you start to fail, the mortality can be up to 80%, which is as high as some of the most lethal cancers out there. So not only very poor mortality, but also very poor quality of life. So who is dying with heart failure? This was a study that was done in Boston, and it looked back retrospectively over the patients who had died with heart failure. They looked 6 months before the heart failure death. What they found is that those patients had renal failure, they had hyponatremia, they were anemic, they had a low ejection fraction, and oftentimes they had right ventricular failure. They also had multiple hospitalizations related to their heart failure. So these are really signals to us, as practitioners, that interventions need to be done and need to be done early. So the natural history of stage D heart failure patients with optimal medical therapy is really poor. So once patients start to progress along heart failure, and we have to pull back on their guidelines-based medical therapy, we know that the outcomes are very poor. So these are optimal medical arms of 2 of our early VAD trials. One was the Rematch Trial, one was called the Intrepid Trial. Both of these were ventricular assist devices. This was they were ventricular assist devices randomized to optimal medical therapy plus or minus inotropes. And you can see that the 1-year mortality was 80% in both of these trials. So very poor survival. So stage D patients. So we want to make sure that we identify our high-risk patients. So again, patients who are having recurrent symptoms of heart failure despite optimal medical therapy, recurrent heart failure admissions. These are the patients who, despite aggressive therapy, even inpatient and outpatient therapy, they're being readmitted to the hospital. It's refractory to medications, rising diuretic doses. They're developing symptoms at rest. And then also very poor quality of life. That's something that us as heart failure doctors really need to focus on, is the quality of life of our patients. So we know that ACE inhibitors and ARBs and beta blockers are really helpful for people at heart failure, but we've also seen those patients who can't tolerate these life-saving therapies. That's also a signal for us that heart failure is progressing. Increased diuretic doses as well. Low blood pressure. Hypotension is a very important marker for advanced heart failure. I mentioned renal insufficiency before, liver dysfunction, hyponatremia, pulmonary hypertension, and right-sided failure are very important to diagnose. And then also, if there's been no response to cardiac resynchronization therapy, also at that point you may consider evaluation for advanced heart failure. So again, early referrals to an advanced heart failure center can really save people's lives. So how do we treat advanced heart failure when it comes along? Well, we can whip the horse give inotropes to these patients with sick hearts, but we know the outcomes really are very poor with that. We can give afterload reduction. Afterload reduction has been a mainstay of heart failure therapy since the 70s. We can give beta blockers, slow the horse down. We can do a heart transplant and get a new horse. We can have Dr. Slaughter put a ventricular assist device in and get a tractor. We're working at healing the horse too, and investigating ways of myocardial recovery, including in combination with ventricular assist devices and aggressive medical therapy, as well as emerging stem cell trials as well. We talked about inotropes. There's limited utility of inotropes. The survival with inotropes in many of the landmark clinical trials didn't show any benefit. In fact, even suggested worse outcomes in some patients treated with inotropes. Ventricular assist devices have come along in the last 10 years or so and really have revolutionized the management of advanced heart failure. We use ventricular assist devices as a bridge to transplant and also as destination therapy, which really is a term that refers to chronic and lifelong support with a left ventricular assist device in those patients who don't qualify for a heart transplant. And then, of course, heart transplantation is really the gold standard treatment for patients with advanced heart failure. We've been doing heart transplants in Louisville since 1984. Our candidacy really is considered up to age 70, but we do have more stringent criteria for patients over the age of 65. we know that not everybody's going to qualify as a candidate for a heart transplant. And so, that's really where we use ventricular assist devices the most these days. And then also, I think it's important to review end-of-life wishes with all of our patients as well, and reviewing advanced directives with all of our patients. Because all of these advanced therapies may not be appropriate for all patients. This slide doesn't project really very well, but when do we consider heart transplant or left ventricular assist devices as destination therapy? And of course, for heart transplant, refractory cardiogenic shock, severe persistent angina, which is unrevascularizable, markedly reduced exercise capacity with a peak MVO2 of less than 10 to 14, recurrent or refractory ventricular arrhythmias, and then left ventricular assist devices for chronic support or destination therapy. They have very similar indications as we do for heart transplant, but these people who are ineligible due to age, due to high pulmonary vascular resistance, due to other comorbidities, or even lack of social support, may qualify somebody as a destination candidate versus a heart bridge to transplant candidate. And then there are many contraindications to these therapies as well, which is why it's very important to really do a very thorough and complete medical evaluation as we're considering these patients. Our current VAD technology, on the left panel here we have the Heartmate 2, and over here on the right we have the Heartwear device. So these are both continuous flow pumps which can be implanted during an open heart surgery. The Heartmate 2 is an axial flow pump, but essentially they work the same way in the fact that they take oxygenated blood out of the left ventricle, pump it through the pump, and then into the ascending aorta. Of course, the pump requires power, and so there's a drive line that exits the skin. It's connected to a system controller, which is then connected to a power source, either batteries or wall power. The Heartwear device works in the same way in the fact that it takes oxygenated blood out of the left ventricle, pumps it into the pump and into the ascending thoracic aorta with a drive line that comes out, exits the skin, is connected to a controller and a power source. So the patient would be ambulatory, walking around with their drive line and their power source and controller. And so we use ventricular assist devices, of course, as a bridge to transplant, occasionally as a bridge to recovery, which is something that's under further investigation right now, for chronic support and destination therapy. And then there are even new and emerging technologies that we can use for short-term support in patients who have critical cardiogenic shock. This is a graph that shows the number of implants of continuous flow left ventricular assist devices over the past several years. So these red bars right here represent the number of implants of continuous flow left ventricular assist devices, and you can see in the last several years the number of implants has drastically increased and is continuing to increase. We also have improving survival. So down here are these two lines are those graphs I showed you before, the optimal medical management arm of those two very early VAD trials. Now you can see where a Heartmate bridge to transplant trial is up here. This is one of the trials that got Dr. Dawson so excited about cardiology and about heart failure care. So we are drastically improving the survival of these patients with the most advanced disease. So this is a report from the INTERMACS registry, which is a registry of continuous flow, or register of ventricular assist devices, but this is looking at continuous flow devices based on level of illness. So level 1 are those patients with critical cardiogenic shock who are implanted with a durable ventricular assist device. And then levels 3 and 4 through 7 here are those patients who are less ill. And you see that the survival in patients who are less ill is a bit better than those patients who have critical cardiogenic shock. Also, so not only is our survival improved, but our quality of life improves as well. And all of these quality of life indicators for heart failure, the Kansas City questionnaire, the EQ5D questionnaire, and then also 6-minute walk, all of these measures are improved. So quality of life is also a very important consideration in our advanced heart failure patients. So the timing of that implant is also very critical. We want to make sure that we don't implant too early, but it's also very critical that we don't implant too late as well. So There comes a time when the operative risk and the risk of death after VAD implant is too severe. So after end organ dysfunction has developed, or liver failure, or cirrhosis from right-sided heart failure. So we want to make sure that we implant before the level of illness becomes too severe that that patient isn't going to survive the surgery itself. Now we'll move on to talking about heart transplant. It's really the gift of human heart. And this has been, we have almost 50 years of information about heart transplant. And it was really hopeful initially. And heart transplant has gone through some ups and downs over the last several decades, but we've really improved. It's not a cure. We're trading one disease process, heart failure, for another, which is chronic immunosuppression. These patients have excellent survival and quality of life, which I'll touch on in a minute. But they also have to take multiple medications in order to achieve that. So the transplanted heart here is beating. This is from Johannesburg, South Africa, after the first heart transplant was performed. The transplanted heart is beating, but many problems have yet to be answered. And over the last 50 years, we've markedly improved the way that we care for advanced heart failure patients. And really, heart transplant is still the gold standard in taking care of advanced heart failure patients. The problem is supply. So this is data from the United Network for Organ Sharing showing that over the last 25 years, or more than that even, there have been about 2,000 to 2,200 heart transplants performed in the United States every year. And this is despite us aggressively teaching people about the benefits of organ donation, and educating, and even statewide pushes for people at the DMV to sign their organ donor forms. But still, despite all that, only about 2,200 heart transplants are performed per year. If we look at the number of patients who are currently listed in the United States for a heart transplant, it's over 5,000. So clearly the math doesn't add up. So we need additional therapies, including heart transplant, but also some of the newer technologies that are coming out have really provided hope for some of us. The survival after a heart transplant is really excellent. In our current era, which is shown here in the purple and the red, median survival is 11 years. If you survive that first year, the median survival is over 14 years. So patients are living decades after having a heart transplant. So the evaluation for heart transplant. First of all, we need to confirm the severity of heart failure. We do that in a number of ways. We need to confirm that there are no other medical or surgical options available. And we need to perform a comprehensive physical evaluation to exclude medical contraindications that may provide poor outcomes after transplant. We need to evaluate the mental health and social support system. We know that those patients who have the best social support system are going to do better after heart transplant. So one of the ways that we evaluate for severity of disease is by cardiopulmonary exercise testing. So these patients who have MVO2 of less than 14 have poor outcomes. And so that's one of the places that we start, particularly on our ambulatory outpatients who are having worsening heart failure symptoms. So the listing status. So the United Network for Organ Sharing came up with these listing statuses for patients with heart transplant. Of course, status 1A patients are your highest priority. They are oftentimes in the intensive care unit on 2 inotropes plus a pulmonary artery line. They have a balloon pump or other temporary mechanical support, or they have a durable mechanical support device like a ventricular assist device that either they can use 30 days of elective 1A time, or if there's a complication of that ventricular assist device, oftentimes we can upgrade their status to 1A to improve their likelihood of getting transplanted. So status 1B are your stable patients with durable VADs, a Heartmate 2 or a Heartwear device. If they're on inotropes at home, but we know that the survival and the utility and the durability of inotropes at home is really limited. So patients who are inotrope dependent, oftentimes we're thinking about a ventricular assist device in these patients. The next level is status 2, and these patients are home on oral therapy. These patients are very unlikely to get transplanted in this day and age. We really stratify patients, and with status 1A and 1B patients are the ones who are most likely to receive a transplant. And you can see status 1 patients, those patients who were not transplanted and remained on the waiting list had a very poor survival compared to those who were transplanted. Some of the determinants for wait time, of course, like I said, there's 2,200 heart transplants performed every year and over 5,000 patients currently on the heart transplant waiting list. So those patients with blood type O are going to have the longest wait time. large body size are going to have a long wait time. And then those patients who have been exposed to other HLA antigens in the past and who have formed antibodies to other HLA antigens are also going to have a longer wait time. And some of the complications of immunosuppression, and this is only a few of them, are hypertension. Almost 80 to 90% of our heart transplant recipients after transplant will be on antihypertensive agents. Hyperlipidemia is a very important consideration for us. Diabetes management always worsens after heart transplant because of corticosteroids and because of the other immunosuppressive agents. So we oftentimes will consult with endocrinologists to help manage diabetes. Renal insufficiency, calcineurin inhibitors, which are one of the mainstay treatments and have revolutionized heart failure or heart transplant care, can oftentimes cause renal insufficiency and can even lead to dialysis, years and decades after heart transplant. Infection, we worry about infection very early, and then we worry about malignancies later on from suppression of the immune system. So some take-home points here. Heart transplant ventricular assist devices improve outcomes in our patients with heart failure, even in the patients with the most severe disease. So we as heart failure cardiologists really look at this very hopeful. We have options to treat these patients versus some cancer chemotherapies that only expect a few months of outcomes. We really change the way people and improve survival, improve quality of life. Ventricular assist devices have really revolutionized the way that we care for patients with advanced heart failure. Early identification of patients at high risk for worsening disease is critical to offer timely life-saving interventions. Patient selection and timing of VAD implant and transplant listing is really critical. And our best outcomes occur with early referral and treatment before irreversible and end organ damage has occurred. All right, I'll take any questions.
We'll take questions at the end of the session, Dr. Lemon. Thank you, Dr.
Thank you very much. Let me see if we got this right. There we go. So first of all, I certainly like to thank Dr. Dawson and the Western Kentucky Heart and Lung Research and Education Foundation for inviting me. It truly is a real honor and a privilege to come and speak. And hopefully you're happy with your career choice, in which case I'm okay with it. If not, I apologize. And the other is I certainly would like to thank Dr. Akbar for raising everyone's awareness of the energy requirements of a sexually active adult population. And for those of you that are concerned that you may exceed the energy expenditure, then we may want to talk about a VAD afterwards. Anyway. But it's a real pleasure. So I'm going to give you a little bit of a different twist on heart failure and some of the things that Dr. Lenneman covered. Similar, but sort of a different take. Originally, I actually was going to be a cancer surgeon, but as a slide he showed you along the way, the idea was that heart failure patients had a much poorer survival, the majority of all patients that had cancer. And even nowadays, right, you live longer if you have HIV than if you have heart failure. So my goal was always to try and sort of take a disease process that essentially was fatal and see if I might be able to have an impact during my lifetime. And I would say I'm still working on it. I'm not sure we've actually achieved the goal yet. I also have a quick disclaimer. I have way too many slides, so I'm going to go very quickly. So these are my disclosures. And I will add, though, that I've never personally received money, but certainly we work with industry because otherwise it's impossible to bring new technology to the patient and the patient's bedside. So I want to go back a little bit. And actually, I'm going to cover maybe about 55 years of heart failure in about 15 minutes or less. But Andy had mentioned, so this is Christian Barnard. He actually trained at the University of Minnesota. And he did the first heart transplant in 1967. And at that time, it was a 59-year-old patient. The patient lived 18 days. Huge success. Everybody's happy, right? So it's 1967. So Norm Shumway, United States, it turns out they both trained together at the University of Minnesota, right? And Barnard went to South Africa. It was easier to do things. But Shumway did the first transplant in the United States, 1968, so just a little bit later. And the patient only lived 14 days. The reason why I bring it up, though, is there's been a lot of resistance to sort of mechanical circulatory support, and the expectations have been markedly different. But if you go back in the history of transplant, essentially nobody lived more than a year. And as a matter of fact, as everyone got on board and got excited about transplant, many programs, there's 20 or 30 within a couple years, but within 5 years, they're back down to 2 programs. There are only Stanford and one other, and the idea was the mortality was still essentially 100%, and by the mid to late 70s, where we were getting reasonably good outcomes, and that was somewhere around a 70% 5-year survival, 5 years, and it cost $350,000 per patient life year saved. No one that would not refer a patient for a heart transplant because it was life-saving and wonderful. But yet we're sort of having the same discussion still years and years with mechanical circulatory support, although we've met those goals and exceeded them many, many years ago. So this was from Dr. Pierce at Penn State, and I had the opportunity to go there and give a talk a couple years ago. And Dr. Pierce has been a pioneer in the development of circulatory support. He'd been at the NIH for 7 years. And so this was, they ran in, they just did the first heart transplant. He'd been working for 7 years already on a mechanical heart, and they told him he could stop his research because we don't need mechanical circulatory support. And even to this day, and this was a review article that he wrote just a few years ago, and it's just the contrary. And as I'll show you using the same slides that Dr. Linneman showed you. And the idea is transplant is the greatest impetus to the development of not only mechanical circulatory support, but new technologies for the treatment of end-stage heart failure. So this is the slide that he showed you, and I'm going to add a few caveats to it. So it's a wonderful treatment. It's the current gold standard. But you have to remember, these are only the people that actually got an organ offer. So still in the United States, up till a couple years ago, up to 20% of patients die while on the waiting list. So these were patients that are otherwise at home undergoing good medical therapy and they don't live. And the answer is why? They weren't even offered therapy. So the idea is the survival overall is good, and he is correct. Then I tell patients, as a rule of thumb, you'll get 10 years. But the other is, when he says decades, it's actually not quite true. So that if you look at the number of patients that actually live 20 years, the answer is it's about 1%. So the ideal age for transplantation is 55 to 65. 45 to 55 is okay, but if you're under 45 years of age, and let's say you happen to be 25 years of age and you have a non-ischemic dilated cardiomyopathy, your goal is not to make it to 30 or 35, you want to make it to 50. And the odds are if I transplant you in your 30s, you're never ever going to get married, you're never going to work again, and you're not going to make it to 50. So the idea is we have to have some other therapy for these patients with advanced heart failure in addition to transplantation. And we're struggling now, I think, with what is the role for transplantation, because another group of patients that are being ignored are women with diastolic heart failure that aren't candidates for VADs. They wait as 2 or 1B, as he pointed out, and they never get an organ offer. So we have to find ways to equally distribute organs. So what about mechanical circulatory support? As I showed you, Dr. Pierce started working on it back in the 1960s. It's not new. It's been around for a long, long time, and it works. And it's worked for quite a while. So this is William Kolff, and I just bring him up because actually I happen to know him. He just died a few years ago, but he did many great things. Actually, he started the first blood bank in Europe. He developed the first artificial kidney. He developed a dialysis machine. He moved to the United States. He was at the Cleveland Clinic. He started their artificial heart program, then moved to Utah. And he started the Utah Artificial Heart Program. And no one knows about it because somehow, the day it got put in, he'd been working on this mechanical heart for about 40 years. And the joke in the lab was that whoever was the senior researcher at the time, when we put it in, oh, we'll name it after you. It was a joke. The person who was working in the lab at the time happened to be Jarvik. And he put on a lab coat, ran out and sat down at the press conference and said, we put in the Jarvik heart. It was not the Jarvik heart, it was the William Kolff heart. And actually, we still use it today. It's not gone away. As a matter of fact, it's a very successful total artificial heart and has a 90% success rate as bridge to transplantation. It did not go away. But this is Bill DeVries. Bill DeVries actually is the one who put it in. William Kolff is the one who designed it. The idea at the time was these people weren't supposed to survive. It was, could we get you to live a little bit to see if the technology worked? And the answer is it did. DeVries subsequently moved to Kentucky, right? He was in Louisville, and the next 5 were put in Louisville, consistently, though, not with good results, as was the Abiacore. So this is a patient of Dr. DeBakey's back in 1966. This was a woman who went in for a mechanical valve. She had what was then called a stone heart. He put her on a circulatory support device. She actually was extubated on her device, sitting in an intensive care unit in 1966. It was subsequently painted with betadine here at the skin. He cut the cannulas, let me see right here, and she went home and lived another 10 years. This was back in 1966. We knew the technology worked. We had to have some improvements, though, in biomaterials, mechanics, powering, and things like that. So this was a drawing from Dr. DeBakey's book in 1969, and the reason why I know is because it had to be reviewed for some legal issues referring to IP. But the idea was if you drew a line right across here, and you look at this part, that was the Abiomed pump and or the Thoratec PVAD. The PVAD was actually the Pierce-Donachie heart developed by Dr. Pierce in Penn State. Worked very well, but this was his drawing. And then the other issue is if you put a line across here, which I'll show you in a minute, and you sort of show the cannulas and just imagine making this smaller, this is a Circulite pump, which has been in use today and is pacemaker-like. So the original drawings were made back in 1966. So it took a while, though. Dr. Kirkland at UAB is a wonderful physician and surgeon, is a great researcher, clinician, and writer. And I would say he and I had some lively debates over the years. It's always been fun. But just a few years ago, he's come to the dark side. And that is, he has written an article now from the database that he has that collects everyone else's results. And he has admitted now that there are outcomes using mechanical circulatory support in non-transplant eligible patients that are equivalent to transplant. And our goal has always been to find a substitute for heart transplantation so we can treat those thousands of patients that Dr. Linneman alluded to that will never ever get a heart and or will die while waiting. So he showed you this slide, and the reason why I put it up again now is, so this was the results of our New England Journal trial. This was by Jim Fang, though, who wrote the editorial, so it wasn't me. He actually drew the graph, actually, to our study. And the idea was this was with pulsatile technology. This was with medical therapy. Medical therapy didn't change. The problem was everyone said that it was not clinically relevant. Well, I would make the argument, even with the pulsatile technology, and I always use the example, is if I had 100 cousins on this side of the room and you had 100 cousins on this side, and mine got a VAD and yours didn't, when we came back at a year, I had 50 cousins. They would go out and play golf afterwards, and on this side, there were 23. They were on oxygen, swollen legs, and they couldn't make up to the podium to say hi. And the issue is, so whose family would you want to be in? And the answer is, if the patient was offered the choice, they wanted to get a device. The problem was they've not been offered therapy, and they still aren't today. The physicians are making the choice for them. So this is now with continuous flow technology. So the improvement in outcome now is due to the new technology. The argument back then was we had to have 70% 2-year survival or they wouldn't refer patients. Well, we clearly now have 70% 2-year survival that I'll show you, but as Dr. Linneman alluded to, patients with advanced heart failure, in the United States, we're seeing less than 1% of them. So not only are they surviving, though, it's very important now, and the AHA has multiple guidelines, and we help write them now, quality of life has to always improve because we don't want them just alive at home, still sitting in a lazy boy and alive, but the answer is they have to be out, active, and enjoying life. And at whatever metric you want to use with mechanical circulatory support, their quality of life improves greatly. And as a matter of fact, it improves more than with any other advanced heart failure therapy, including ICDs and BiV pacemakers. So this issue of when to refer. So we've known this for quite a while. And before, and I didn't put it in, majority of patients are referred in that very slippery slope of stage D heart failure where they are going to be dead in 6 to 12 months. The problem is at that point they have irreversible end organ failure. We try to save them. We can save many of them. But the answer is, long-term survival is not necessarily great. This was part of the Heartmate 2 destination therapy trial that we did. And in it, what was approved by the FDA was you could include 3B patients. Now, 3B patient doesn't exist in any guidelines, but we sort of know they're more than 3, less than 4. We sort of know who they are. It's like I know evil when I see it. I just can't describe it as a definition, right? But the idea was they were included in the trial. So if you look at hemodynamics, age, everything else, it's essentially identical. Elevated creatinine, elderly patients, high pulmonary pressures. So this is what happens. So if they were 3B, a little bit less sick. So the majority of them were still on inotropes. 96% went home, right? They went home a week sooner, and median survival was almost 2 years. And this was 6 years ago, okay? We knew this 6 years ago. So Andy Boyle, who was at University of Minnesota and then went to Milwaukee, he's a cardiologist, very aggressive, great guy. And so when he got there, they sort of restarted their program. So he decided, why are we waiting? So Andy basically recreated the same thing. Dr. Lindeman touched on this Intermax 1, they're the sickest. 2 is the next sick, and then 2 or 3, 4 through 7 is less sick. And just very quickly, if you look though, the idea is that if you are in sort of this sort of mid-range group, at 3 years, it was 94% survival, better than heart transplantation. So the idea is, and this was also published multiple years ago. So what does make a difference? So does age make a difference? No. So chronologic age is not a big determinant. Physiologic age, yes, but not chronologic age. So what about gender? They absolutely not. The reason why I bring it up, though, right, is as many women die of heart failure as men. Do you know how many women actually get devices? It's 20%, right? So of all devices put in, they're men. All the women are just dying at home of heart failure. So what does make a difference? Right heart failure. So right heart failure significantly impacts your early survival as well as long-term survival. And for the majority of these patients, the right heart failure is just due to chronically elevated LVDP, ventricular dilatation, the development of mitral insufficiency, pulmonary hypertension, and then chronic RV failure. So the issue is you need to see them before they develop significant and irreversible right heart dysfunction. Now, there certainly are issues with mechanical circulatory support, and I don't mean to imply that they're magic and there's no issues. And we can certainly spend another hour talking about them. An unsort of suspected issue is this sort of development of mucosal bleeding. It's somewhere around sort of 12 to 15% of patients. It's manageable, but it is an issue. With current devices, 100% of them will develop type 2 acquired von Willebrand's. We also now, because patients are living 5+ years, there are patients that develop aortic insufficiency due to this change in gradient across the aortic valve. And certainly there are some patients that will either develop thrombus in the heart or in the device that can cause complications. So Dr. Lindeman had started to touch on this and mentioned the Intermax category. So this is sort of crash and burn. They're in the ICU. We might try it, but not very often. These are patients that are sort of inotrope dependent in an ICU, on inotropes. And this is where we're now talking about where we should be, are patients with advanced heart failure where you have to decrease the beta blocker, their creatinine rose a little bit, or their hematocrit is dropped. And drop means a hemoglobin of 11, not 8 or 9, but 11. And the idea is somewhere in here is the ideal time to see these patients. So as he alluded to, and it's shown in this slide, I use it for other reasons too, but if you look in the bridge to transplant group now, it's 90% survival in patients that are transplant eligible out to a year plus. And we showed you the slide of transplant, and as a rule of thumb at most programs, it's an 80% 1-year survival, and that's the Medicare goal. Well, the answer is we're doing better with devices, and I'll show you some additional information, and I'll speed up here a little bit more. So this is from Duke, actually. So Duke has what they call an alternative list. So these are patients that maybe aren't transplant eligible, maybe are, we can't quite decide, so they gave them an option. We'll list you for transplant today, and you go on the list and you wait, and not only do you wait, we're going to give you a marginal organ, or you can have a VAD today. And so this was the original result. So this was the Rematch trial. And the idea was a DT VAD was clearly better than just staying on medical therapy. But there was some suggestion that, well, maybe transplant was still better once you got out to 2 years. The problem was they didn't take out the people who said, okay, I'll list you today and let's see what happens. 15 to 20% of them died. So they put them in the next graph. And the fact of the matter then is if you include the patients who died while waiting, there's no difference out to 2+ years. Then the other issue was they included the old pulsatile technology, which I showed you worked but is inferior to current technology. So you include the new miniaturized continuous flow pumps, and here's the outcome at Duke if you offer a patient bridge to transplantation, a device, permanent use, or a transplant. There's no difference. Okay? Now, we still don't know as we get closer to 10 years, but certainly out to about 5+ years, there's no difference. And this was at Duke. So here was our experience when I first arrived at Louisville. So a year we offered them the same. Now we got lucky that year and we had 0 mortality out to about 2 years in heart transplantation, and that's unheard of. We just got lucky. But the idea was the patients that got a device, we had the same outcome. There were 2 deaths. One person died of diabetic ketoacidosis. Well, they weren't a transplant candidate anyway, and they probably shouldn't have had. And the other one was a guy at home at 18 months on his tractor mowing his grass with his headphones on listening to music. Unfortunately, he didn't hear his batteries go off, that they were low, and unfortunately his battery stopped while mowing the grass, and by the time he realized it, he got in the house, he fibrillated and died. So that's our fault. We can get better with the alarms, but once again, outcomes out to about 2 years, and our hands are also the same. There's also this issue of, oh, with VADs, they get admitted, and we have this GI bleeding issue and whatnot. We do have issues. So does transplant. So in that same group of patients, you compare them, length of stay for the initial therapy is essentially the same. You go home in 2 to 3 weeks after a heart transplant or a VAD. Total length of stay out to 1 year is no difference. Average number of readmissions is 4, whether you have a VAD or a transplant. What about cost? So we've done this numerous times, whether it's destination therapy or bridge to transplant, and generally speaking, you can round it off. So for a device, it's about $200,000. Of that, it's the cost of the device, and it's about $120,000. So the idea is if you look at pre-surgery days, a little bit longer for the patients getting a device, and that's not necessarily true anymore, but back then it was. So after the device or transplant, cost is the same. So you look at it, and the difference in cost is it costs $30,000 to acquire a biological heart, and it costs $110,000 to get a mechanical heart. As price comes down, there'll be no difference. And this does not include the cost of right heart biopsies and immunosuppression. And if you include those at 1 year, there is no difference. So where are we with devices right now? So what about the waiting list? So we talked about the people that are dying. Should these people just be sitting on the list, still in heart failure, waiting for a transplant? So this is looking at the UNOS waiting list, and we actually matched the patients. So we did propensity matching. So the idea was you either had a device, in this case it was a Heartmate 2, or you did not. So it means you're in a hospital, in an ICU, on inotropes, or at home. So you had to be 1A or 1B. And here's the outcome. So the survival actually for people waiting for transplant in the UNOS database, this is the United States Registry, you have a better chance of surviving the transplant if you have a VAD than if you don't. So what about if you have a VAD, does it complicate the transplant afterwards? Well, the answer is for the surgeon, is it technically more challenging? The answer is absolutely. And you have to have a dedicated team and people and whatnot. Mike Acker from Penn actually just published their results at the University of Pennsylvania, and he came to the same conclusion. It's a much smaller number. Once again, we use the UNOS database. And if you look at this, so these are patients without a device being transplanted. These are patients with a device being transplanted. There's no difference in outcome. And as a matter of fact, as we look into it more, there is some suggestion that actually the patients on a device long-term may actually have better survival. And the reason is they have better renal function at the time they have their heart transplantation, because the patients without a device still are in heart failure, have renal insufficiency or hypotensive, and are at risk then for perioperative renal dysfunction. So what about patients waiting? So Europe has made a huge mistake. Just like everywhere else, the number of patients on the list has gone up, donors have gone down. So they've been very aggressive about still transplanting patients, and they've been using marginal donors. Their outcomes now have dropped dramatically, and now Europeans are unwilling to donate their family's organs because they just assume the recipient is going to die anyway. So we know what the outcome for the marginal heart is. And it's very important that you sort of define what a marginal heart is. But anyway, we use standard sort of definitions of it. Usually it's an older person, maybe some coronary disease, maybe a leaky valve. You go ahead and use it. But anyway, so here's the marginal donor group. Here's patients who got an LVAD. And once again, this is from the UNOS database. So this is from the United States Registry. So here's what it is. So the idea is, here's the outcome at 3 years with a marginal heart. It's not bad, but we know what happens between year 5 and 10. And it's not the graph Dr. Lenneman showed you or I showed you. It drops off drastically. So the survival while waiting is the same with a VAD. So the answer is, why are we throwing bad hearts into people when they can survive just as long with a device and we can wait and give them a good heart? So I think we need to rethink the role of transplantation and how we divvy up hearts. So we've had tremendous changes in circulatory support. So we mentioned this is the Pierce-Donicke, the PVAD owned by Thortec. It works very well. These are pulsatile implantable devices, quite large, a little difficult. Heartmate 2, which was a huge for the field, moving things forward, and further miniaturization, and we're getting very, very close to having a pacemaker-like device that will give you support that will be done as an outpatient and you go home the same day. Even with current devices now, depending upon the patient, not everybody, but this is one of our patients from Jewish Hospital, University of Louisville, we now put them in through a very small thoracotomy, not on bypass. So for many of these patients, you don't go on bypass. These are their decisions afterwards, right? It's almost less invasive than coronary bypass surgery and someone has renal failure, right? You would still refer those patients and we would treat them. But this is, oops, I guess I'm done. So thank you very much. We were going to talk about recovery.
I have a question, actually. I know Dr. Lenneman mentioned patients, with inotropic support, we know they probably do not do well. So inotropic support has to be a bridge to something. Meaning if the patient is in the ICU, the critical care unit, and you cannot get that patient to be with all heart failure symptoms. They're having symptoms at rest, and they're very hypotensive, and you need some amount of support. Of course, you can start them on inotropic support, but it has to be a bridge to something if you cannot wean it off. There has to be an attempt to wean it off at least once, and if you're unable to wean it off, what else can be done? And that's where we get referrals for more advanced heart failure therapists, whether for LVAD evaluation or heart transplant or both. So if those patients are evaluated and they do not meet the criteria, and hospice is another option, and patients can go home on inotropic support with hospice to wean off because their quality of life during that short period of time is better. And so if nothing else can be done, hospice is always something to think about, but still supporting the patient, making the quality of life okay while they're still, if they're not a candidate. Can you guys touch more on that?
I'll let him follow, but you raise a very important point, and even as part of our sort of VAD and heart transplant team is palliative care. So a palliative care person is part of our decision-making team, and they actually see every patient. Because we have to be very careful, because even in some of these elderly patients, although it all sounds like it's perfect and whatnot, these people are very sick. It's a big operation, and it's very important that they really understand what it means, what the recovery process will be, and to make sure it's really what they want. And so it's important that they get sort of an unbiased opinion, and we have a palliative care person see all these patients as well to make sure that they're fully informed, or at least as best as we can.
What is the incidence of thrombosis? That's my first question. The other question is, what's the guidelines in a patient with end-stage renal disease? Is around 50 years of age?
Yeah. So the incidence of thrombosis varies a little bit based upon the patient and the device. And so as a rule of thumb, it's probably, when we talk about all thromboembolic events, probably somewhere around 5%. And the majority of those manifestations are hemolysis and pump dysfunction. And for those patients, some of them can be treated with aggressive thrombolytic therapy or pump exchange. But the devastating complication would be a thromboembolic stroke. If it's a hemorrhagic stroke, as a rule of thumb, it's fatal. It's very difficult for them to sort of recover from a hemorrhagic stroke. Now, I always get a little bit careful because in most of the studies and experiences, it's probably total somewhere around 8% in that range. So the idea is, though, if you look at the AHA data, though, by decade, the incidence of stroke in someone in their 60s or 70s is somewhere around 2 to 5% on an annual basis, depending upon other underlying factors such as hypertension, AFib, ventricular dilatation, all these things. So the presence of a VAD probably increases the risk of stroke by about 3 to 4%, something like that. We will certainly want to get it lower, no question about it, and there are ways that we can do it. So it's not insignificant, but somewhere around there. And the renal failure is a real problem for us these days. And the reason is that if the renal failure is relatively acute and is reversible, then actually they will do well long-term on a VAD. The issue is if they're really going to be on chronic dialysis, the intermittent access most likely and has been demonstrated to result in transient bacteremia. And it may or may not be important in the absence of a VAD, but with a VAD, it's a problem because then it gets seeded. So if those patients ultimately are a candidate for a heart-kidney transplant, the answer is yes. We would certainly consider it because then we can bridge them to a heart-kidney. If their outcome is going to be destination therapy, meaning a VAD only, then it's generally speaking not a good idea, and we would say no.
Can you complete your presentation?
Oh, sure. I think I have like 5 more. And I would So I'll tell you real quick. But so I think the exciting part, though, is not only is to use mechanical circuit support, though, as sort of permanent use or an artificial heart or LVAD or whatever configuration, but as a platform for therapy. And so in that aspect, the idea is what else can we use the VAD for? And that is to basically sort of regrow hearts and to recover hearts. And this is where I think it's very exciting. So this is a normal sort of elliptical heart on the left. Here's somebody with heart failure. And the issue is, how can we make this heart look like this again? And is it possible? So this is Doris Taylor's approach and some others. And you always hear about how people want to grow a heart. Personally, I mean, it's great. It's, interesting research. We learn a lot, but I don't think it's actually practical. The idea is there's not an individual myocyte, right? You have to have conducting fibers, Purkinje fibers. You have to have atrial tissue, ventricular tissue. Someday we might be able to do it, but not in the foreseeable future. So the idea is they take a heart and with detergents, they make it acellular. Then you repopulate it and somehow you're going to recreate this heart that works as well as ours. And the idea is I don't think that's reasonable. Because the other is, and this is a heart with non-ischemic dilated cardiomyopathy, right? So the coronary arteries are normal. They've never had a heart attack. And what I always like to point out, though, and this is why medical therapy ultimately fails, is they all have subendocardial ischemia. They all develop scar, and scar doesn't squeeze. It won't squeeze. But as opposed to Doris Taylor and some others, I don't understand why she wants to wash out all the red stuff. Red is good, blue is bad. And once again if they do okay with a 30% ejection fraction and no MR, that's all I've got to get them back to. And they will do very well with medical therapy. So why do I want to use a detergent and wash out all of this? All I want to do is try and replace some of the blue. So is there a way to do it? And the answer is yes. So injecting cells alone also has not had great success and never will, because you can't take an individual cell and put it in a very hostile environment where the extracellular matrix is not ready to accept it and allow it to grow and integrate. So somehow you actually have to change the extracellular matrix in which you're going to put this cell, or you want to develop a new myocyte. So actually this is some others, but we've developed a model of heart failure. It mimics human heart failure. We can talk about it at length. So what we've been able to do is take extracellular matrix, emulsify it so you maintain its sort of structure. We've developed a new tool so that you can directly inject it into these areas of blue. You can identify it by echo. And the idea then is that by changing the extracellular matrix, then if I want to put in a cell goo or it turns out naturally occurring progenitor cells, c-KIT positive cells, circulating mesenchymal cells will actually be naturally attracted. This is the tool that we've developed. So this is what happens. So this is a normal, this is heart failure, this is LVAD only, this is extracellular matrix only, this is VAD plus ECM. They're normal. So we can demonstrate this. If you look at end organ blood flow, we can demonstrate normal end organ blood flow. And this is the exciting part. So this is the scarring part that we talked about. This is with LVAD only, ECM only. Here's VAD plus ECM. The blue part's all gone. So you're able to save the red, which is good, and replace the blue. And the other is, so this is using Brdu staining. So these are nuclei. These are sarcomeres. So these are actually myocytes. So these are new cells, right? Brdu stains for new cells. You overlay them. So we actually have created new cardiac muscle. So by using extracellular matrix, we actually have grown new muscle, and we've replaced it. So the idea is rotary blunt pumps have contributed to the growth of the field and improved long-term outcomes. With longer support times, additional effects on cardiovascular system become evident. Some of those complications we talked about. We're now starting to realize our vision of a mechanical off-the-shelf alternative to transplantation and refining patient selection in a less sick patient, right? We don't want to do someone that doesn't need the therapy or technology, but we've got to get them before they're actually dying, will significantly improve our outcomes. And then myocardial recovery is possible in selected patients with non-ischemic cardiomyopathy. Thank you very much, and I apologize for the interruption.
Thank you, Dr. Linneman and Dr. Slaughter. Two excellent presentations. I have a quick question. When I was at University of Florida, we did probably about 40 VADs in the year I was there, and many of those probably took care of about 80 VAD patients. Many of those patients were referred from communities just like this. I would like for you to talk about shared care and referral of these patients and how they come back to the community. If any of you could comment.
Great, absolutely. We would love to expand our life-saving therapies to all people across the state of Kentucky, and I think it's important to note too that we want to partner with people all across the state and in the region so that we can. It's also important to know that many of our patients can't travel as much. So if we can bring the care to them, and also many of our patients really value the relationships that they build with their home local cardiologists. So much of what Kentucky is all about is about communities, and so if we can bring our care to them, we would love that. Of course, a lot of the initial therapies would need to be done at one place, but then afterward, the aftercare can certainly be done closer to the patient's home and ease burden on patients and families. I think that's.
Yeah, so I agree, and I'm a huge fan of sort of shared care programs and sort of the hub and spoke. And I know Thoratec's here. I don't know if other ones are. So Thoratec years ago, while we were in Chicago, it helped us develop sort of the hub and spoke program. We're actually develop programs that actually do evaluation, do all the tests, send it with a package, and it works. Certainly those helping then to take care of the patients have to have some experience and be interested, but it's getting close to the point where it is managing hypertension, INRs, some other illnesses and some knowledge of the new technology, but it's certainly doable, and it's a way to get the technology and the treatment to a greater population.
Any other questions? All right, in the interest of time, we will have to move on to session 4. Thank you very much.